so we can stay. Hello, everyone. Good afternoon. It is now officially 12 o'clock, so I can say afternoon. Hope you're well. Enjoying this beautiful day that Jean and I were just talking about. Nice day to be opening the windows. Thanks for being here. We appreciate it. I want to introduce, everyone I think knows Jean Acevedo. She has quite a following, but I'm going to go ahead and give you a little brief update for those of you who haven't had the pleasure of hearing Jean or don't know about Jean. Jean has been in the business for over 30 years. She's got an expertise in chart audits, compliance, education. She's been an expert witness in civil litigation as well as federal fraud cases, and serves as an investigative consultant for the DOJ and the FBI. So don't mess with Jean. We're really glad to have her, and she is the backbone of this healthcare connection for many, many years, and our coding and Medicare updates always very, very popular. I do want to let everyone know that this is being recorded. So if you want to share with your staff after, you're certainly welcome to do. We encourage you to do so. And to invite you to an upcoming town hall we have on February 24th. It's going to be a legislative update from 6 to 7. So be on the lookout for the Zoom invite. Do we have any circle of friends with us this afternoon? If so, I'd like you to introduce yourselves and say hi. No? Okay. All practice managers. I know a couple are probably coming in late, but without any further ado, we're going to have Jean and Zoe, her co-host, are going to get started. Thanks for being here today.
Thanks, Deanna. Thank you, guys. Good afternoon. Yep. Good afternoon. It's noontime. It's a beautiful day in South Florida. A beautiful day in the neighborhood, as the dear Mr. Rogers would have said, right? So, all right. So this is the one presentation that I do every year where I always mention my disclaimer. It's early in the year. We haven't quite been a month into 2021, but aren't we all happy that 2020 is behind us?
Yes.
So for any of you who've been through my talks for the coding and Medicare update, fill in the blank for the year, you know I follow a certain format. But everything's new, right? So I'm using CPT codebook, ICD-10. I understand that the 2021 HCPCS books came in my office, but I'm sitting at my kitchen table. So I'm doing the best. And the final Medicare physician fee schedule rule. And as a matter of fact, in addition to the fee schedule rule, at the very end of 2020, over the holidays, there was another COVID Relief Act that passed and got signed into law that changed a thing or two. So I'm hoping that by the time I'm finished today, that this information is all still current. It's all my disclaimer means. And at this time of year, you know, I'm always stressing, be on the lookout for MedLearn Matters articles, etc., for further clarification of changes, answering questions and all of that. So, all right. So where are we going today? Go over some highlights from ICD-10. I know that you've had your ICD-10 code books and have, I'm sure, updated everything 3 or 4 months ago, but there are a couple of things I want to point out in case you didn't notice. And then CPT changes, and then without the book, what I've been able to pick up for HCPCS. And then probably about half the time on, all right, so what the heck is in the Medicare physician fee schedule rule for this year that doctor practices need to be aware of? And if you think about it, since I never know who my audience is, especially as we go through the coding changes, some of you will sit through something that has nothing to do with the specialty you work in, right? But I won't spend more time than needed. Hopefully there's a little bit of something for everybody. All right, ICD-10. There weren't too many changes for this calendar year. They started in October. 74,000 codes. There were only 90 new ones. But just to point out to you, because I know folks don't typically go to their code books for diagnosis codes at the beginning of the year to see what's different. Just to point out a couple of areas that now have diagnoses because these circumstances didn't exist. Obviously, COVID-19, right? But also because of these opioid substance abuse issues we have. Fentanyl poisoning has new codes, you know, narcotic use disorders have new codes. And then because of vaping, for goodness sake, there are vaping use disorder ICD-10 codes. So, different things that it would be helpful if you know that you're doctors, or if you are a physician, that you know that, oh, sometimes I see a patient, but that I didn't know there was a way to report that. Important that you do so. I will just briefly talk about the changes that started on January 1 for how clinicians are to document office visits, right? Because that's a whole other talk, right? Which I've already done for the Medical Society. And there's probably a recording somewhere up on their website that anybody who would want to have some detail could sit through. But the fact of the matter is that since you're choosing your office visit codes based on complexity, being able to document or paint a picture on your claim as to how complex was the patient, how do you do that? It's only through diagnosis codes. So if there are comorbid conditions that you're addressing, the good way to avoid the payer coming after to look for your documentation for that level 4 visit, right? If you've kind of told them up front how complex the patient was. And then 58 deleted codes. Some of them you will want to check out, because like R51, the general headache code, it doesn't exist anymore because there are more specific codes for headaches that have been created, so and you do want to capture those things so that you don't wind up with denials and claims that you have to then rework. Some of the areas for those, how many was it? 90 new codes have to do with the musculoskeletal section of the book. So I put a couple of examples up here. There's an A suffix that's been added for rheumatoid arthritis for other specified sites. And there are other codes with other specified site or other specified joint. And because that was a pretty across the board change, I thought I'd take this opportunity, a moment, to just remind everybody what other specified means versus unspecified. Right? And I think the best way to explain it is to share with you what a physician in Palm Beach County, who, when we went from ICD-9 to ICD-10, was sitting with me and trying to understand the rules, because they were so much more important with the granularity of ICD-10 that was about to come, that said it to me this way: Jean, I think I've got it. Unspecified is a doctor problem. If the code goes out with unspecified site, location, side, et cetera, that means I, as the doctor, haven't documented enough for the code to be as specific as it should be. Other specified is a coding problem. That means I've documented specifically what's going on with the patient, the causation, et cetera, but there isn't a code that is that granular to speak to that. And I love the way he said that, because I think it puts it into plain English as opposed to the rules that's in the code book, right? So obviously, if other specified site would never be used, or other specified joint would never be used if indeed there was a code that addressed the site or the joint that you actually were treating, right? So, but many changes there. So musculoskeletal section, for any of the codes that you look at, worthwhile looking in your book. For anybody who doesn't get a book every year, which I can't imagine, but okay, that's me, the coder. You can go to the CDC's website and if you search, you can find PDF files of the different sections of the current ICD-10 code book. Right, so the tabular list where most of us would go to really code something, the diagnosis of the signs or symptoms, you can download the PDF of just that. And I know a lot of physicians and other clinicians really like that. Heck, I like it, because I typically download it, because that way I can just do a Control F and do a search for the terminology I'm looking for, right? The other thing about ICD-10 that I find really, really interesting is this. So when ICD-10 first came out, I had noticed that there were all these codes that spoke to circumstances, social determinations of health, which you've got the definition up there. And I found it really interesting, because I had the pleasure of working with some of the physicians in the community through committees and things with the Medical Society and the Services Division, that have made me acutely aware of like triple aim and things like that. other things, right, that impact the health of an individual or community. And because that there are an awful lot of new codes in that area this year as well, I'm bringing it up for this reason. Again, because of the changes in office visit documentation and coding, there are these three little elements, not so little, but the same element that gives you risk of patient management, is it prescription drug management, et cetera, also adds a component of complexity if there is a social determinant of health that is impacting whether or not the patient can actually afford the treatment or get the treatment, et cetera. So where there is a social determinant of health that is adding to the complexity of the doctor, the nurse practitioner, physician assistants, medical decision-making, you want to become somewhat familiar with that because it actually can add to the complexity of the office visit code, right? So now we're talking that it could actually impact payment. So to give you an idea of a few of those, as you can see, they're in the Z section: occupational exposure to dust, homelessness. Think about, we'd have to have our head in the sands, right, to not be aware of the teenagers that are homeless and still going to school. So if I'm a juvenile diabetic, and I'm homeless, well, that's clearly going to have a negative detrimental effect on my overall health, right? So reporting that as a tertiary diagnosis, never primary, these wouldn't be primary diagnoses, right, is important. Or the patient that you see that admits that, well, I take every other dose of my pill, or I cut it in half because I can't afford it, right? So that low income Z59.6, et cetera, right? Patient intentional underdosing of medication regimen due to financial hardship, right? So all of these things are important and they do add to the complexity, right? Especially that last one. So for anybody who's interested, or if you know your doctor would be interested, I've given you the link to the CDC's website where you can find more of that stuff. All right, so that's really all on ICD-10 that I think is interesting to share with you guys. CPT and HCPCS. Starting at the beginning of the book, that's typically how I do this, right? And this talk forces me to know what the changes are because I literally have to take the CPT code book, start at page 1 and go flip through and look for all the new codes, the revised codes, and any revisions to the guidelines and parenthetical notes. So it starts with evaluation and management. So yep, major changes this year. First thing you might notice is that there is no longer a level 1 new patient office visit. That you may not have noticed because nobody ever billed for it. So that code's been deleted. There are major changes to the 8 office visit codes that remain that physicians, non-physician practitioners would use. Yeah, there's still 99211. It's not impacted by any of this. But there really are just 8 codes, important 8 codes that have changed dramatically. 99202 through 05 for new patients, and 99212 through 15 for established patients. No more 3 key components. I mean, if I was a doctor, I'd be doing a mental happy dance every time I thought about the fact that, wow, if I just document what I've asked the patient about how they're feeling and whether or not they have any symptoms in this way or that way, I no longer need that big review of systems that half the time I didn't know what was in it anyway. And patients coming with shoulder pain, I don't have to listen to the heart and lungs just to meet the codes requirements. Those things are all gone. I would definitely be doing a mental happy dance. So office visit codes now are chosen based on one of 2 ways. What was the complexity of medical decision-making? With only a clinically appropriate history or exam required. And because it's just clinically appropriate, the clinician's decision for this patient at this visit, nobody's going to be counting any bullets. Yay. Or how much time was spent pre-visit, intra-visit, post-visit on the date of the visit, including documenting in the EMR as long as that happens the date you actually saw the patient. So to give you an idea as to then, all right, so what is the definition? I've excerpted it at the bottom here of this slide and just put in parentheses anything that would be different from any one of the 8 codes. So office or other outpatient visit for the evaluation and management of a either new or established patient, which requires a medically appropriate history and or examination, and then depending on which level we're talking about, straightforward, low, moderate, or high medical decision-making. So that's the same narrative for a new patient as an established patient. So for doctors as well, nice to know that regardless of new patient or established patient, the way to choose the code based on complexity is exactly the same. So, and a little bit of less complexity just even with that. And then when using time for code selection, then there's a range of minutes depending on the level, right? Minutes of total time is spent on the date of the encounter. That's it. We internally have had to totally revamp our audit tools, our little pocket cards we give when we do education for docs, etc. So because there is such a dramatic change to office visits, the entire evaluation and management section of the code book has been revamped. It now starts off with, excuse me, an overview of evaluation and management services in general. Then it has a section on guidelines that are common to all evaluation and management. And that subsection in there about time, because of what's happened with office visits, has been totally changed, because it's still the case that for other services, the only instance where you can use time is when more than 50% of that time is in counseling, coordination of care, et cetera. The AMA is having its CBT editorial panel meeting the end of next week. I know I'll be attending it virtually. And I know there are more changes coming for 2022 for E&M. I'm hoping that they'll actually be rolling out the office visit changes to other E&M codes, because it really does reduce physician burden. So, and then there are specific guidelines for non-office visit codes and how to choose the level of service for non-office visit codes. So hospital, observation, inpatient, consults, emergency department, home visits, etc. And then of course, for office visits, there's a whole new section. And I would urge everybody who has anything to do with coding the office visits that you read the section about office visits, and particularly pay attention to the about 4 pages or so that have definitions that didn't exist before January 2021. There is now a definition for what does it mean to have a problem that's addressed. And for most doctors, nurse practitioners, PAs, it's important so that they don't code the wrong level of service, either under or over, right? Also, things like stable chronic illness. Suddenly, it's a term I've used for 20 some odd years. I guess I thought that there was an accepted definition. Now there is a definition, right? So knowing all that stuff is important. If you have an office practice, I can't imagine how, if I was the clinician, how I would feel comfortable coding without having actually read these new requirements, definitions, terms, guidelines, instructions, and also sat through some education, right? So, because it really is a sea change, but in the end, it's a good change, right? You know, so. I get, and some of you remember that I'm always talking about this, in addition to the CPT code book, the AMA CPT changes and insider's view each year, because since I never know what I'm going to be dealing with, I need more information about the entire book. And that's the book that gives the AMA's rationale for new codes, clinical examples, et cetera. And when I went to that to look for what does it say about the office visits, I found something really interesting in that the clinical examples show for each of the 8 office visit codes that they're split up in 3 like subsections. What's expected within 3 days prior to the visit, the day of the visit, and then within 7 days after the visit. And when I first saw that, in case any of you get that book or get it and see it, you might have the same concern I did, which was, wait a minute, is this suddenly taking the activities that maybe were leading up to the visit and what I, the doctor, might do after the visit for the next week, and somehow bundling into the visit so that maybe I couldn't charge for something within a week after the visit, right? So I went back and forth, even had one of my colleagues in my consulting firm go back to the physician fee schedule rule to see if we could figure it out. I haven't been able to figure it out. But do know that in choosing the office visit code level based on time, the only time that you can include is the time spent with and or for the patient on the date of the visit, regardless of what you might see there. That would just throw a wrench and stuff. So just to, since it's a 2 to 4 hour talk on the new office visits themselves, to make sure that you're clear on a couple of general facts. The changes to E&M documentation and coding impacts just these 8 codes, just these 8 visit codes. All other codes for visits, all other evaluation and management services continue to have to be met by the 1995 or 1997 evaluation and management documentation guidelines, including office consults, right? So, and that's something for the specialists in particular, primary care doing pre-op consults, right? For medical clearance, that I want to make sure folks understand that what you've been doing all along for years still applies to those codes as well, at least for now. I know the AMA is working on making that not be the case. And the other thing that's important is that this is not just a Medicare thing. This is a change in CPT, so it's all payers, right? Which is, again, a good thing, right? You don't have to worry about, well, Medicare likes it this way, but United wants it that way, or Florida Blue, et cetera. Nope, it's a change and across the board, which also, if you think about it, when it comes to audits, means that even the payers, coders, and auditors are learning this stuff. So I think there's probably going to be a little bit of grace period while everybody learns it. So I doubt that there'll be too many, if any, audits of office visits, the beginning, at least the first half of this year, maybe not even really this year, unless someone obviously just bills all level 5s. Well, then all bets are off. You're just asking for an audit, right? So that's it on that. Now, there was also another change, again, a good one, for the time-based codes. So this is actually prompted by the Medicare program, surprisingly to me, delightfully surprising. Medicare actually, in working with the AMA on changing the codes, was doing its best to try to prompt the system, right, so the coding reimbursement system, to pay more for doctors, not only cognitive abilities, but the time spent sometimes with complex patients. And where there have always been prolonged services codes, or at least for many, many, many years, their description included that it was the first additional hour, right? And to get to a first additional hour, you always had to have at least passed the midpoint. So it's at least 31 minutes, right? So Medicare was pushing the AMA successfully to, hey, let's develop codes that would allow doctors to be paid when there's a lot less time than an hour that was spent, like each 15 minutes. So the AMA came out with 99417 in the CPT code book. Prolonged office or other outpatient evaluation and management service beyond the minimum required time, blah, 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 right? Each 15 minutes. Only to be used for level 5 office visit codes. And if you look at the codes in the book and you look at their time, it makes sense. A 99214 is 30 to 39 minutes. A 99215 is 40 to 54 minutes. Why would you add 15 minutes to the 1.4? It just becomes a level 5, right? So clearly it's only for level 5s. But, and the reason that I've got a couple of phrase in the 2 codes that you see, underlined and bolded, is that after CMS published the proposed physician fee schedule rule for this year, the AMA tweaked a little bit the definition of their 99417. In its initial form, it said beyond the maximum required time. After the proposed rule came out, they changed it to beyond the minimum required time. And I remember looking at that going, okay, wait a minute. So a level 5 established patient is 40 to 54 minutes. If it's 15 minutes beyond the minimum time, 40 plus 15, that's at 55 minutes that you're supposed to bill for each 15 minutes, but that's really just 1 minute beyond the time that you might spend in a level 5. I was mentally scratching my head and thinking, what is Medicare going to do about that? Something tells me they're not going to just go along with that. Instincts were good. Because in the final physician fee schedule rule, suddenly there was another code, G2212. Prolonged office or other outpatient evaluation and management service beyond the maximum required time, right? So we have 2 codes for each additional 15 minutes that can be billed with a level 5 office visit, assuming the time has actually been met. One can be billed to Medicare and one cannot. So if it's a Medicare patient or a payer that follows Medicare requirements, G2212 would be billed for each additional 15 minutes beyond a level 5 office visit spent on the date of the visit, whether face-to-face or non-face-to-face. And if it's just a commercial plan that doesn't follow Medicare guidelines and honor HCPCS codes, it'd be 99417. And obviously the time would be different. So because one's at the minimum, one's at the maximum. So 99215, again, 40 to 54 minutes. So if it's a commercial plan and you spend 55 minutes, minimum of 40 plus 15, that's when you can bill 99215 and 99417. But Medicare is beyond the maximum. So 40 to 54 plus 15 on the 54 is 69. So 99215 plus G2212 at 69 minutes, right? So, so that's that. But that's good because if you think about it, it's only each additional 15 minutes. There was a bit of complexity added now that we have 2 codes, but a lot easier to get to 15 minutes of additional time than it is to get to an hour. All right. Chronic care management in this section of the code book, I have the description of 99490 there. It hasn't changed, but I put it there only because there's now a new add-on code, 99349, for, is that right, or is it a typo? For each additional 20 minutes of clinical staff time. There was, up until this year, a HCPCS code, G2058, for each additional 20 minutes of clinical staff time. That's now been deleted and replaced with a CPT code book for that. So if you're providing chronic care management and it's your medical assistant, office nurse, some clinical staff is doing it, and they spend 40 minutes this month providing the chronic care management services, you get to bill the practice 99490 plus the additional 20 minutes code now with the CPT code rather than the HCPCS. All right, that's all I could find in the E&M section of the book. Anesthesia, I couldn't find any changes, not codes, not guidelines, so moving on. Surgical section, integumentary. Remember, this is broken down into different systems. So I didn't find any new codes, but there were some new guidelines. So for anybody doing repair and or reconstruction of the breast, you're gonna want to go in and look at the guidelines to make sure that you are coding correctly. Right, and your documentation supports the guidelines. And I can't tell you how important this is. There's a physician in another part of the state who is now under what's called a corporate integrity agreement for the government, thinking that he was badly upcoding complex repairs. And it's so much of it is semantics based on changes that happened to the guidelines last year in 2020 as to how a clinician, particularly a dermatologist or Mohs surgeon, needs to document the complex repair, right? So when you see revised guidelines changes, not only should whoever is in charge of coding and billing and payments be reading that, but making sure that the clinician who's providing and documenting the service is aware, because the semantical changes can make a difference in the clinical documentation. If a payer asks for the notes, whether or not you fly through the payer's request with all A's, or if you find yourself under the microscope. Musculoskeletal system and surgery, couldn't find any changes, so moving on. Respiratory, new code 30468 for repair of a nasal valve collapse with a subcutaneous or submucosal lateral wall implants. The code doesn't say whether it's unilateral or bilateral. So for anybody doing this, no, it's a bilateral code. So if the physician was to only do the left or the right side, this would have to be billed with modifier 52 to report a reduced service. Right? So in a couple of other guidelines there. Also in this section 32408, core needle biopsy of the lung or mediastinum, percutaneous, including imaging guidance when performed. So remember, anytime you see including imaging guidance in the description means that you cannot separately bill for the imaging guidance. Right? So, and there I do spot a typo. That first code should be 76942. So no ultrasound guidance, no fluoro, et cetera. Right? And so that's an important area to be looking in code description, whether or not it includes imaging guidance so that you don't unbundle inappropriately. And the subsection guidelines in this section for core needle biopsy procedures have been totally revised. So not only, there may be only one code that's changed, but the guidelines have, again, really important that not only coding and billing, but also the clinicians performing the procedures understand the changes so that they can tweak their documentation if appropriate to meet the guidelines that are now required. Oh, before I forget, and that's one of the reasons why that book, that I always call it a companion book, the CPT Changes for the Year in Insider's View, can be so helpful. So if you're listening and any one or more of these areas, you go, yeah, we do that, and oh, we do that. It's worth the $70, $74 to get the CPT changes. If you order it from Amazon, you'll probably get it in 3 days, right? If not earlier, unless if you're a Prime member. Because that way it actually gives, not as I mentioned before, the rationale, but for the doctors or non-physician practitioners, also clinical examples that will help guide them as to what needs to be documented or what exactly that code encompasses, right? So that they make sure the clinician understands, oh, okay, I thought maybe I would use it when I do X. Oh no, it's really for Y, right? So, and then in the cardiovascular system, there weren't that many changes this year for a change. Cardiovascular always seems to have some of the highest number of new revised, deleted codes, et cetera. This year for pacemaker, implantable defibrillators section, that there's a new category 3 code, 0614T. So there are some changes here in the guidelines and the table for those procedures. The table, having a table in CPT for these is not new, but the table has been updated for the new code. And there are new codes for shunting procedures. And because of that, those subsection guidelines have been totally revised as well. For GU, this sometimes has no changes, maybe one. This year there are 2. New code 55880, ablation of malignant prostate tissue, transrectal with high intensity focused ultrasound, including ultrasound guidance. Now, if I was in person, I'd ask, so how many of you think that you could bill separately for the ultrasound guidance? And I'd hope that no hands would go up because I just finished telling you when it says includes it, you can't get to bill separately, right? So, and then a new add-on code, 57465 for computer aided mapping of cervix uteri during colposcopy, right? And then of course it also has some includes things, right? That would not be billed separately. The auditory system, there are 2 new codes for surgical nasopharyngoscopy. One, 69705 when it's performed unilaterally for dilation of the eustachian tube, and the same procedure but bilateral for 69706 for our otolaryngologists. All right, that was kind of it for the surgical section of the book, the highlights. I'm sure there's a code or 2 revised or something that I didn't hit on, but the ones that stuck out to me. Radiology, only 6 revised codes, couple of deleted, 2 new codes. The first one is really going to only be of interest probably to most imaging centers, although I know we have at least one practice in town that does have a low-dose CT scanner. And when you're doing that screening for lung cancer, for smokers, current, or those who were, I forgot the criteria off the top of my head, that was at least a pack a day for 30 years and hadn't quit within more than 15 years, et cetera. 100% payable by the Medicare program as a screening service. There's been this G code that was around since the benefit was created. G0297 has been deleted. Took a long time for this AMA to make a CPT code for this. 71271, CT thorax, low dose for lung cancer screening without contrast. And then for the radiation oncologist, just a new code 76145, medical physics dose evaluation for radiation exposure that exceeds institutional threshold, including report. Hopefully nobody in town is going to have to bill that. Pathology and lab. So interesting. So first I'm going to look at that last bullet. more than 50 new codes for the PLA. What is that, proprietary lab something? And every time I do this talk, I ask the same question. No one gets back to me. So I'm assuming I'm not the only one that doesn't know what the heck are these codes? Who uses them? I haven't had the time to do research to figure it out, but this section of the pathology and lab in CPT keeps growing. And I'm like, well, who's using these codes and for what purpose? For your purposes, in the beginning of the book, there's a growing number. There were some new ones last year and about 37 or so, or about 30 some odd new this year in the therapeutic drug assay subsection, right? And those are the codes like new one 80143 for Tylenol, 80204 for methotrexate. So this would be a lab test that would tell the doctor what's the level of that drug in the patient's blood. And the reason I point that out is that you need to understand that, one, you don't necessarily want to add it to your repertoire of services if you have an in-office lab, nor necessarily even ordered for the patient, because unless there is an accepted in the medical community level, right, that is the that is too much, right? So there's too much dilantin in the blood, or you know, the ideal that you want to reach that's accepted clinically that would make a difference in treatment. Nobody's paying for these. You know, last year there was, I forget what the drug was, it was a fairly commonly prescribed drug that Medicare came right out because I think they had a feeling that they'd see a lot of folks billing for the level of that there wasn't any consensus or benefit in getting the level. It'd be like, okay, so you know how much of Tylenol is in the blood. What are you going to do about it, right? So just because it's the code, I have these 10 iron rules of Medicare that I use in a slide when I do a compliance talk that I've been using for like 20 years, never gets old. One of the numbers is just because it has a code doesn't mean you can bill for it. And then the next one is just because you can bill for it doesn't mean you get paid. That's what these therapeutic drug assay codes are. So be careful before you use them, and just in case someone has spotted them. In the medicine section of the book, so we get to the end of the CPT codes, 18 new codes, 4 revised, 8 deleted codes, nothing that stuck out as much. You know, there are always changes in the immunization section. You know, what I found interesting this year was in the guidelines section of this subsection of the medicine section of CPT, this statement: if a significant, whoops, that cute little puppy that some of you saw is protecting me with her 10 pounds of life. Hopefully that was a quick bark and she's done. If a significant separately identifiable evaluation and management service is performed, the appropriate evaluation and management service code should be reported in addition to the vaccine and toxoid administration code. I found that, why did I find that interesting? Because one, the only way you're going to get paid for an evaluation management service with an administration code for any vaccine is what? Modifier 25 on the visit code, right? And that modifier 25 being that is highly scrutinized by payers. In fact, over the last 3 months, there have been a number of physicians throughout the country, here in Florida and other practices we work with in other states, who have gotten what I call those infamous love letters from a Medicare contractor saying that you doctor, have more evaluation management visits billed with a modifier 25 on the same day as an injection or procedure, right? Well, administration of a vaccine or toxoid, that's an injection, right? So it's always scrutinized because there is a component of evaluation and management that is expected the clinician will perform before giving any vaccine. For anybody who's been lucky enough, I have, to get their first COVID vaccine, there's a series of questions, right, that are asked, you know, before I got my shot. They would not have been treating me properly if they gave the shot without asking the question. So included in the vaccine, do you have a fever today, et cetera? Allergic to any substance in the medication? All of those things that we get asked every year, even when we get a flu shot. no separate visit. So my thought was that for the AMA to insert this language in this section of the code book, they are doing their best, the AMA being the they, to give physicians some authoritative source documentation. Should you get a denial from a payer for billing an office visit with some vaccine or other immunization administration, that the payer says, no, they're included in each other, that at least you know you've got a quote from the CPT code book itself that you can appeal saying, no, 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 we did a separately identifiable evaluation management service. Patient got their flu shot, yeah, but they were here for follow-up of their hypertension, right? Had nothing to do with the flu shot. So that's a good thing. And then because we have so many new vaccines, no shocker to you guys, I thought it might be more helpful than showing you that whatever's new in the book the day that I did these slides, but to provide you with the website where you can check what is the current list of new vaccines, because we're going to be seeing new vaccine codes with any luck, right? Over the next few months. So there's the URL that you can check the AMA's website for new codes for any newer revised vaccine products that come out, including the COVID, right? So I thought that might be more helpful. In the psychiatry section of the medicine section of the book, if we have any mental health professionals attending today, codes didn't change, but the guidelines changed substantially. So again, important to go read them. I don't know about the books you guys get. Mine, the guidelines and subsection guidelines always that are changed, any revisions are written in a pale green font. So I can spot them easily. I'm hoping that you can as well. And then the dialysis section had some guideline changes, but mainly to reflect the fact that 99201 is no longer a code, right? So anything that would be there that tell you that it couldn't be billed with, right? Obviously that's a change. Anybody doing audiology, especially on little humans, babies and infants, there are some new codes for audiologic function tests. In fact, there are 4 of them. And these are broken out more like I'm used to seeing for a lot of cardiology testing. So think about it. If you're doing, diagnostic testing very often has a component of an interpretation and a report, right? A CBC doesn't, but a chest x-ray does. Okay. In imaging, typically to show that, oh, I just did the interpretation report, the patient had the study over there, right? I would bill the code with a 26 modifier, right? To show that, oh, only paid me for the professional component. Except there are cardiology testing, EKGs for one, that are broken down so that there's separate code, 93,000 EKG, including the technical component and the doctor's interpretation and report, versus 93005. Nope, we just did the test, we didn't interpret it, versus 93010. Wasn't our test, I just did the interpretation and report. Shouldn't say just. So a lot of that there. So now for the auditory evoked potentials, they've done a similar thing in this section of the code book, which I don't know why it's sometimes or the other, right? It just adds a level of complexity. So 92650 would be automated analysis. 92651 would be the evoked potentials with an interpretation and report. But then if you go down to, oh no, this isn't actually the one, there's another one, sorry. So this one is broken down into the different intentions for doing the audiologic function test. But again, here we go with cardiology, here we go, right? Where they've done it again with new tests. So a lot of monitoring out there. So we have a new set of codes this year for external electrocardiographic recordings, 93241 for more than 48 hours and up to 7 days, 93245, more than 7 days, up to 15 days. And as you can see, the 2 codes I pointed out are global, right? It's the technical component, including storage, the recording, scanning analysis, and the report and interpretation by the physician. But if you're only doing the recording, or you're only doing the scanning analysis of the report, or you're only doing the review and interpretation, or any combination of those two of those three, then you would build the subcodes depending on the amount of time, right? Why is it that they do that with cardiology? Anybody know? This is a new code for the book, but it came out actually in September. And we in my little group have gotten a fair number of questions about, hey, we're doing so much more now when patients come to the office. Any way we can get paid for the extra effort? We're taking everybody's temperature. We're asking screening questions. We're really sanitizing the rooms more. We have to buy Purell. We have to have masks. This is all an unexpected expense when patients come to the office. So the AMA in September created the code 99072, good intention, additional supplies, materials, and clinical staff time over and above those usually included in an office visit or other non-facility service. So anytime the patient comes to the office for service, when performed during a public health emergency is defined by law due to respiratory transmitted infections. So pretty much limited to COVID, right? Good thought. I can't find anybody who's paying for it. The AMA even clearly defines what's expected to be in this. And I know as I've gotten out and about to some of my own doctors, they go through this all the time, right? So Medicare, unfortunately, had come out soon after this code was created to let the community know that the Medicare program considered it bundled into whatever the office code was that was billed for the day. And as I've asked practice managers, and if one of you knows and can put it in the chat or something, if you found that one of our payers here in Florida is paying, that'd be a good thing. I haven't found anybody yet that would tell me that, yeah, in Florida, X payer is paying for this. Whether or not you should put it on the claim, as an ex-practice manager, I think I would. Why would I if nobody's paying for it? Well, I probably wouldn't put it on the Medicare claim. Although if I did, I'd probably put a zero charge or 1 cent so that Medicare couldn't accuse my doctor of trying to get paid for something that I knew was bundled, right? Don't want the federal government accusing us of unbundling. But I also know that there have been times in the past where something suddenly in April, in July, is suddenly payable as the physician community lobbies for itself, advocates for itself. But the only people who got paid for it once they finally, the payer community overturned their original determination are those who had billed for it originally. So I think I might this year bill for it to maybe, I don't know how much, what, $5, $10, something, just to try to get compensated for that. If for no other reason that eventually down the line, just academically, I'd be interested, but no reason to do it otherwise. But I'm always thinking about, wait, maybe down the road, someone will pay for that. All right, HCPCS changes, as I mentioned, I think the books finally came in my office, but I haven't been there to pick mine up. I've scattered a couple of codes throughout the presentation. And as I mentioned before, there was one code, the each 20 minutes for chronic care management by clinical staff, that was deleted, the G2058, and replaced by the CPT code 99439. So this is just duplicative, just showing it in the reverse. There was a couple of HCPCS codes that I picked up because I did download the database, right? So the Excel file with the codes to try to see, okay, is there anything that I really want to know so I can share it? So many of you, hopefully all of you actually, are aware of the virtual check-in code, the G2012 that came out, was it 2020 or was it actually 2019? Anyway, it predated the public health emergency. This was that, okay, the patient calls, the doctor, the nurse practitioner either takes the call right then or calls the patient back. And it's not that you're managing anything, it's just that the patient is asking questions and you're trying to figure out what's the next steps. Do they need a new lab test? Do they need to make an appointment, right? And as long as that's documented, the call, the doctor, the nurse practitioner PA got to bill G2012 for a virtual check-in, deciding what's next. Well, as CMS is realizing that there are some things in telehealth that they will not be able to continue once all of the public health emergencies come to an end, but do understand the importance of this, right? I guess they like the idea of the patients actually speaking to the provider, because no, it can't be that you relay a message to your office nurse and have her call the patient back. They've created for this year another code, G2252, has pretty much the same definition as G2012, except that rather than 5 to 10 minutes, it's 11 to 20 minutes of medical discussion. So after the public health emergency, it's in place now, right? So if you're not having a medical discussion, there's no treatment. It's not a visit over the phone, right? It's like, no, don't worry about that. Just keep your appointment for next week. But if the discussion to determine that takes at least 11 minutes, you can bill G2252, right? So interesting. This is a side of CMS that I don't think any of us have been used to seeing, as to when there's what they call the stakeholder community, right? So you guys and me, right? The providers, the physicians, and their advocates have said, wait, thank you for X, but that doesn't cover the totality of that situation that CMS has come up with. Oh, okay, we didn't know that. Here, how about this? And that's what this G2252 is. Okay, it for the codes. Physician fee schedule. What things change? What do you need to know? Let's look at that. So the conversion factor, well, this was going to go down a lot, by about 11% when the fee schedule first came out, the proposed fee schedule, because of everything having to be budget neutral in our Part B world. And the Medicare program was going to be paying more for office visits, and initially had an add-on code for most doctors to be able to use. And the specialists and the AMA, who weren't going to benefit from that, but were going to take the hit by the decrease in the conversion factor, lobbied CMS to do away with the budget neutrality thing if they could this year or anything. And the Medicare program, I think they felt their hands were pretty much tied. They only changed the conversion factor a little bit. So, because it was like $30 and change to $32.40, right? But then we had the COVID Relief Act that got promulgated at the end of the year. And those same doctors, and again, understandably, I don't mean it in a pejorative sense, lobbied now Congress saying, hey, in the public health emergency, we appreciate you trying to pay these doctors like internists and all a little bit more. They don't have, high cost procedures to make a living, but can't you do that and somehow not harm me as well, right? So they went to Congress, and Congress actually did take action. So they did raise the conversion factor a little more. So the hit to those doctors is nowhere near as bad as it was. And the reason you need to know the conversion factor is if you have any managed care plan contracts that are paying you on or off either the Medicare fee schedule or conversion factor, since it's gone up since last year, you want to make sure your payments have gone up, right? And then if any of you still think that there's this add-on code for complexity, G2211, yeah, I think it's actually in the book, but there's no payment for it because the physician community did indeed lobby Congress successfully to delay payment for that for 3 years, so that there is no payment for G2211. So it should not be going out on office visit claims. But a good thing for all doctors was that the elimination of the 2% reduction for sequestration that was supposed to start again January has been held off again through the end of March. So that's good. So there is an increase for everybody pretty much across the board. And if you look at office visits alone for here in Palm Beach County, you can see that there in some instances are a substantial difference. So a level 4 established patient visit went from about $112 to $135. So that's over $20 additional in the allowable every time you see a level 4 patient. And for those of you who have gotten educated on the new office visit guidelines, they're probably also thinking right now that, oh yeah, and I have more level 4s now because it's so much easier based on the new requirements to get to a level 4, right? So, you know, it did have a positive impact, some of these changes for pretty much everybody. Because I mentioned the public health emergency, do know that it has been extended before the change in administration. Secretary Azar at the beginning of the month extended it for another 90 days. It was supposed to end about January 21st. So we now have the public health emergency on a federal level through April 20th, 2021. And this means that all the things that you've been doing under telehealth that are because of the public health emergency will be in effect till at least April 20th. My instincts tell me, and I was on a national regulatory committee with an organization yesterday, that the chatter in Washington is that it'll probably wind up keep being extended probably through the end of the year, right? But right now, through April 20th. And for anybody who wants, there's the link to, at least when I went there, to the actual statement by Secretary Azar. There are categories of telehealth then that you need to be aware of, because I'm assuming that probably everybody that is listening does some. So briefly, go over a couple of them. So what has the Medicare program in the final physician fee schedule rule permanently added to the Medicare telehealth benefit, regardless of whether or not we're in a telehealth emergency? Here's the list. What I find interesting is that we have some low-level established patient home visits and ALF visits that are added, and but only low-level, which I find very interesting. Why not a more complex patient? Oh well. And that new prolonged services code for each additional 15 minutes for level 5 office visits, G2212 as well. And then there's, some psych services, mental health that are going to be permanently added to telehealth as well on a go-forward basis. Then there is a second category that will remain payable through the end of the public health emergency. Through the end of the calendar year in which the public health emergency ends. So if indeed the public health emergency is not extended beyond April 20th, all of these services will remain as payable in the Medicare program through December 31st, 2021. Now look at the first two here. Here we have higher level ALF and home visit codes. I still don't get why the lower level ones will be permanent, and if the patient's sicker, so it really needs to be seen more and more involved, that emergency department visits, nursing home, discharge day management, psychological, neuropsychological testing, some physical occupational therapy that can be done via telehealth, hospital discharge day management, some inpatient neonatal, intensive critical care, et cetera. End-stage renal disease, the monthly capitation will stay, right? Good for the nephrologist. Subsequent observation care. So these will be at the very least in place with the current relaxation of the rules through the end of 2021, right? So that's nice to know. And the reason that CMS, at least my opinion, is that why they're saying to the end of the calendar year is that there are things, even if you think about what happened in January on the 7th, which is not even 2 weeks or barely 2 weeks before the public health emergency was to end this month, is when we found out that it was being extended. Well, 2 weeks notice in a medical practice as to what I can and cannot do virtually is not enough because you've got patients scheduled out, right? So nice that they're giving, all that lead time, for when it finally happens. The good, the bad, right? The good news would be that we're out of this. The bad would be, wait, I have to worry about whether or not this is payable anymore. And then the third category, what is just not going to be payable? The day after the public health emergency ends, right? So if April 20th, that's it, April 21st, nothing on this slide will be payable anymore via telehealth. So if you've been doing any initial hospital visits or initial nursing facility visits, any radiation treatment management, seeing a new patient at home or in assisted living will no longer be payable on, if it should end on April 20th, on April 21st, the inpatient neonatal and intensive care, et cetera, right? So interesting. No, I do not know the logic as to how CMS chose some of these, but depending on your practice and what you're doing from a telehealth, telemedicine perspective, it's nice for you to have this information. That was in the final physician fee schedule rule. Along with all of that, for subsequent nursing facility visits under the telehealth benefit in general, one of the things that CMS also finalized was the frequency at which a patient could be seen in follow-up at a nursing home via telehealth. Prior to the public health emergency, you could only have one telehealth visit every 30 days, right? During the public health emergency, because they obviously didn't want people even going to the nursing home unless you had to, they made it once every 14 days. Well, they must be working because that's going to be permanent, right? CMS also realized that, oh, wait a minute, there are other folks such as clinical psychologists, licensed clinical social workers, physical occupational therapists, speech language pathologists, who if they can't do telehealth, how do they communicate at all beyond any public health emergency? If they can't see the patient in person, how do they actually provide treatment? So they created two new codes that kind of mirror the virtual check-in. So that G2012 is very similar to that, or is actually the same as the G2251, the second code here, that these other non-physician practitioners can bill for that brief check-in, right? And the G2250 mirrors a code I didn't talk about, the G2010. So that's when the patient sends you, uploads a photo via text, a little video. You know, you're the pediatrician and mom says, look at the rash on little Johnny, right? And sends you the picture of it. You look at the picture, you, the doctor, and get back to the patient with your advice and opinion within the next 24 hours, right? Then, you know, that's a billable service today, G2010, but only for folks who can bill office visits. So physicians, nurse practitioners, physician assistants. So to make sure that other folks who can and are Medicare providers can also have that ability, they've created these two other codes. Some other things that were finalized. So those of you who do any incident to billing, patients come in for their B12 shot. People come in you're an oncologist, they're coming in for their infusion. Any other service where you know you're billing incident to, right? The person who personally provided the service was not the doctor whose name was on the claim, right? One of the requirements for that billing is what? Doctor in the office suite, right? During the public health emergency, they allowed that direct supervision, doctor in the office suite, could be met via audio and video. So true telehealth, audio, video, not just telephone, audio, video. So separately from just what services could be provided via telehealth, CMS said, we need to make this something, the direct supervision via real-time interactive audio video. We need to finalize that as a policy to allow these office services to continue without making the doctor come in just to sit there in case there was a need, right? So that's also this new definition of direct supervision will also be through the end of the public health emergency or December 31st, 2021, whichever comes later. And then I put this quote from the final rule in here because I've also gotten this question. And what's the question? You can read the answer. You can read CMS's comment. So I get this question. So Jean, my doctor went to the hospital and the patient was in isolation for COVID. So he, at the nurse's station, FaceTimed the patient. That's telehealth, right? No, it's not. So as you can see, CMS also has gotten this question. So they have reiterated that If you're you, the provider, in the same location, i.e. the same building as the patient, that's not telehealth. You may be using some technology, but it's not telehealth. So you'd have to use the code for an in-person visit for whatever you may have done in person. I know I've asked one nurse practitioner who asked me about this, because as she was talking, it was clear that there was glass for the room, right? It wasn't a hospital room door that was solid and no way to see the patient unless you walked in. I said, okay, so what physical exam could you do by observation through the glass? And were you talking to the patient and looking at them? You're just using a device to hear what they were saying, right? So know that if you're in the same building as the patient, however you're seeing the patient, can't bill it as telehealth. All right, couple of other things. Appropriate use criteria. I actually already had someone who told me, Jean, we have a hospital that is not a hospital, but an imaging center at the hospital that is saying that if my doctors don't access the clinical decision support mechanism and provide the information to them, they can't get paid for the MRIs we're ordering. And I had to tell them, nope, that's not the case. This has been delayed until 2022. Thank goodness. So one more thing you don't have to worry about. Another area when it comes to payment in the final rule that I found so interesting. Yeah, I actually enjoy to a point reading that 2,000-page final rule when it comes out. So some doctors, say the nephrologists who are, doing their monthly end-stage renal disease, visits, right? Where there's different codes depending on how many visits you made to the patient that month, or doctors who are providing and billing for transitional care management services, or the OB, because remember, not everybody who's got Medicare is over 65. You could be disabled, and so there are maternity benefits, right? And you see this list here, right? So a lot of these folks in their specialty societies said to CMS, wait a minute, you're changing the relative value units for office visits. Our services that you pay us for, this lump, right? So it's inclusive of more than just a day, et cetera, or it is just the day, but you base that payment initially on the payment for office visits because there's a component of an office visit in this service. If you're going to increase the RVUs for the office visit, shouldn't we get a concomitant increase in these services as well? And for those on this slide, CMS eventually said, oh, yes. So anybody who's providing any of these services should see an increase in the payment. The one service that I can think of that got lobbied to CMS and CMS said no would be the ophthalmologic visit. So the 92002 or 92004 and 92012 and 14. Because they don't look at all like an office visit and it's typical or a plain vanilla office visit. So they didn't increase it there. So it's limited to this list, but that's also nice to know that they did. And how smart of the physicians to go back and say, hey, wait a minute, if you're increasing the RVUs for this, part of my payment for this other thing over here was based on that. Shouldn't you be increasing my payment as well, right? Good for those guys who are paying, really paying attention. There were some scope of practice changes in the final rule. This first one I find so interesting because when I do a talk on Incident 2 billing, I always try to remind people that Incident 2 is a Medicare benefit and you can only apply the criteria for a service that doesn't have its own benefit category. And I'll often reference diagnostic tests, which is a Medicare benefit with its own category, just like inpatient hospital is or home health, et cetera, right? And then wind up saying that, it's an odd thing, but they've never updated this language in the Social Security Act that says that there must be physician supervision of the diagnostic test to include any non-physician practitioners. So CMS has changed that nicely. So supervision of diagnostic tests is now allowed by nurse practitioners, certified nurse specialists, physician assistants, and certified nurse midwives and CRNAs. The only thing of caution, because I'm talking to a group of Florida people, is that in Florida, we have this Florida Patient Self-Referral Act of 1992. So it's 20, 30 years old, that requires for certain diagnostic tests that there be a Florida licensed physician in the office suite at the time certain imaging studies are done. So before anybody starts saying, oh, good, now when my doctor goes on his Mediterranean cruise, once they open the cruise lines, the nurse practitioner can supervise X tests that we do in the office. It's within her scope of practice anyway. It was just this funky law that didn't allow it. You need to make sure that we can do it in Florida. And then as only really as a clarification, but something that wasn't really thought about before was pharmacists. Can pharmacists provide services in an office and have it be billed incident to the doctor? And I actually worked with a group that had asked that question of me probably a year and a half or so ago. And I had said yes, because I couldn't find anything that would tell me no. And my organization I was working with got plenty of pushback from other folks. And it was difficult for me to even find something to support. I was looking at it as that, how do I prove a negative, right? So CMS, I guess, has also gotten that. Hey, can a pharmacist be in a doctor's office and provide, whether it be polypharmacy education, how to best take a drug, go over the meds with the patients, et cetera? Can they do stuff and bill it under the doctor? CMS has made it clear that, yes, pharmacists may provide services incident to a physician. Obviously, all incident to requirements need to be met, including that direct supervision. And all of that. So, but that's a good thing depending on the size of your organization. And if you have, or especially oncology practices, it's not uncommon for an oncology practice to have a pharmacist on staff, right? So that was a change in scope of practice, which is a good thing. I was not aware that a physical therapy assistant could not provide maintenance therapy services under the therapist plan of care. I'm glad I didn't know, because now that's not a thing. Now therapy assistants can provide maintenance therapy services. And this is something that CMS keeps talking about, and I wouldn't want to then, of course, not mention it, but I don't know who's using this. Physicians and non-physician practitioners, including some not just PAs and nurse practitioners, but physical occupational therapists, are able to, quote, review and verify documentation entered into the medical record by members of their medical team and have it count for today's services. CMS keeps saying this. This is like the third year in a row. I don't know why they think it's such a big thing, because I haven't found anybody who finds this advantageous. All right, we're getting to the end. Remote patient monitoring. There's several slides on this. I am not going to go over all of it. You have the information. And the reason that I wanted to give you as much information, it will be on the slides, is that I keep finding more and more technology that is allowing doctors to remotely monitoring many different physiologic areas of a patient's functioning. So, and it's because technology keeps growing. It's a fascinating little field, right? So there have been some changes, some relaxation of rules during the public health emergency. Some of them will remain after the public health emergency. Remember, this isn't telehealth, separate section, separate Medicare benefit, separate section of the CPT code book. So right now you could be doing remote patient monitoring for even a new patient, because the public health emergency has actually allowed a lot of services that are kind of remote to be done on new patients when the code definitions themselves just speak to established patients. But public health emergency ends, we're going to be back to established patient only for remote patient monitoring. Recognizing that most remote patient monitoring is being provided to the doctor's patient with the involvement of some outside company, right? So doctors don't have the equipment and whatever the center is that is actually doing the monitoring, et cetera, right? That's something that you enter into some type of an agreement, typically with a company who has all of this, has the devices, et cetera. So it kind of has made it difficult. Well, what does the doctor get to bill for, right? Not my personnel, et cetera. So CMS in the final rule clarified that auxiliary personnel may include contracted employees. Yay. So if you're using remote patient monitoring, I would ask you to look at the agreement you have with that company and make sure that It speaks to the fact that whoever services you're billing for, their personnel as yours, that while they're monitoring your patients and whatever interaction they have with your patients, that you've got the right language in the agreement to meet incident to billing. So other little thing is the fact that the device itself must be one that meets the FDA's definition of a, quote, medical device. And that's really important for any of you who are thinking about doing this, because this is a new area. There are some ethically challenged, to use a nice term, polite term, folks out there going to doctors, telling them that here's a device, here's what we would charge you, you can monitor X, Y, and Z, right? It's this little app, whatever it might be, but it's not an FDA approved, doesn't meet the FDA definition of a medical device. So be real careful with that. I can see audits down the road sometime in the future, so be aware of that. For anybody who's doing remote patient monitoring now, and since this is typically for a 30-day period that the patient gets monitored, it's been allowed during the public health emergency that there be at least 2 days worth of data that gets actually reviewed and interpreted. Once the public health emergency ends, it'll be back up to the code's definition. So a minimum of 16 days worth of data in the 30-day period, right? So, you know, some few things like that, you can read the rest. In transitional care management, thank goodness, CMS has relaxed the rules so that if you're providing transitional care management for a patient who was discharged from the hospital in January, you could indeed have chronic care management in January as well, and your monthly capitation benefit from quality of care and overall reduction in Medicare costs when patients can avail themselves of these non-face-to-face or kind of, you know, global bundled codes and not being so restrictive. So that's a good thing. Some of you may have been aware that there was a federal mandate that if you're prescribing a controlled substance to a Medicare beneficiary who has Part D drug coverage, that you had to do that as of January 1, 3.5 weeks ago, via electronic mechanism. So they backed off a little. The effective date is still 1/1/21, but only the government can say it's effective this date, but you don't have to be in compliance until Y. So as of now, the compliance date is January 1st, 2022, right? In acknowledgement of, wait, you don't really want to make doctors go through another hoop, do you, for more regulatory requirements in the middle of this pandemic when everybody's, you know, treading water, so to speak, right? So do know that that will be a thing come January 1st, 2022, unless, of course, we're at the end of the year and we haven't gotten much better. Oh, I can't imagine that, right? I don't think any of us want to think that. It better be that by January 1st, 2022, we're all feeling pretty good about the situation. So a little bit of a reprieve on that. So get working this year on figuring out how you're going to do that. Okay, I think that's it. Those were your highlights. There's definitely a lot going on this year. And I'm really hoping that each of you will have taken at least one pearl, right? So let me check the chat. Yeah, there'll be a recording. Handouts were sent. Happy birthday to my puppy. Oh, I have to stay muted because I have a parrot that will talk the entire time. Oh, that's hysterical, whoever that is.
That's
Oh, I love it. Oh, that's too cute. Thanks for sharing that, whoever that was. I love it. Yeah, you know, it's so funny in this environment we're living in, you know. I've been on serious business meetings and watched somebody's cat walk past them, right? We're on a Zoom or something. So lot going on. Most of it this year, thank goodness, as you can see, most of it good stuff. You know, as someone who's always afraid being a coding and compliance professional, that my message is so very often gloom and doom. I don't feel so bad this year. Right?
Yes. Get a
So,
gold star.
yeah, right. So thank you all. And
Thank you.
I'm done.
Thank you, Jean. And we'll get the handouts to everyone. And a super job as always, and enjoy this beautiful afternoon. And I say everybody go home, enjoy the weekend.
There we go. There we go. Can I tell my boss that you
I'll call Chris. I'll call Chris.
All right, thanks.
Bye-bye.
All right, bye now.